Okay. Okay, great. So hi everyone, and welcome to the second episode of the Refractive Surgery Basic webinar series that we organized with the Eye Department of Hadassah Medical Center in Jerusalem and Ein Tal Hadassah Laser Institute. And for tonight, it's a huge honor to have on board and on stage two of the big master of refractive surgery. It's really an honor, guys, to have you here. That's a huge honor for the whole national refractive community here in Israel. So a few things we have here. I think it's obviously useless to present two of these big masters, but I will still say a couple of words. Professor Renato Ambrosio, current president of ISRS, pioneer in the development of many tools based on artificial intelligence for detecting keratoconus. We'll talk tonight about Pentacam and beyond. He will tell us about the technology, about all the indices he is developing, and about the day of tomorrow with the addition of biomechanic tool, I'm sure. Renato, again, thanks a lot for being with us tonight. And Professor Ronald Krueger, which is my personal mentor in refractive surgery. So it's a very special honor to have you tonight. So Ron is obviously one of the brightest refractive surgeons you guys all know. We'll talk about ectasis screening with Pentacam, and we'll start to put together different machine and discuss with us many challenging cases with different machines. He's today the chair of ophthalmology department at the University of Nebraka Medical. And before that, he was the head of the refractive surgery at the Cleveland Clinic. And as a moderator, we have a team from Hadassah Ophthalmology together with me, my dear friend, Professor Avi Solomon, which is director of the cornea unit at the Hadassah Medical Center. He's one of the leading refractive surgeons in Israel and the past president of the Refractive Society of Refractive Surgery Society in Israel. So we'll start with Renato. You can share your screen, I guess. And we look forward to hear your beautiful and exciting talk, guys.
Thank you. So, thank you very much. So you can see my screen now. I think it's loading.
Yeah, perfect.
So it's an honor to participate. Thank you, David. Thank you, Dr. Solomon. It's a pleasure to participate with you in this talk on Pentacam and beyond refractive screening. I do have financial disclosure, of course, including Oculus, with whom I have the privilege to collaborate over the last 15 years. I also have collaborated with the BRAIN, the Brazilian Artificial Intelligence Network in Medicine. We completed 10 years last year, and also have a master class on multimodal imaging, over 20 hours that is being translated to English pretty soon. So if you are interested, you have this logo here on the, which is covering much deeper what we are going to say in this talk. So I start with a quote that we have to be humble and always willing to learn more. And because knowing enough to think we are right and not enough to know we are wrong is something that we face ourselves continuously. And refractive surgery is a very evolving field, a fastly evolving field. And I also like this quote from The Art of War, that we have to know ourselves and the enemies What will be the enemies that we have to battle for is the complications after laser vision correction, after refractive surgery. So imaging is going to help us to evaluate the tear film, to screen for ectasia risk, to diagnose keratoconus, not only diagnose, but prognostic factors, classification, staging, detailed follow-up. In terms of refractive surgery, astigmatism characterization for laser vision correction, and also for cataract surgery for premium IOL planning. Of course, endothelium evaluation is very important. I do believe there are two subspecialties in cornea. One is keratoconus, the other one is related to Fuchs. And of course, laser vision correction planning, evaluating post-op, educating the patient, and much more to come. All of this is done with multimodal imaging. We have the anamnesis, slit lamp topography. We have ocular surface imaging, tomography, the Scheinfeld, which we'll cover today. We have whole eye wavefront, which I learned from Ron Krueger. I probably believe he remembers when I interviewed him when I was a resident in the late 90s, early 2000s, when he was introducing ocular wavefront and customized ablations. And all of this is integrated so that we have imaging for planning refractive surgery, and the cornea, and the lens, and aphakic IOLs, ocular biometry, segmental tomography, OCT, and high-frequency ultrasound for epithelial thickness, ocular biomechanics, cell evaluation with confocal and spectral microscopy, and genetics is coming as very close today. So topography has been around for a long time, but the question a lot of people ask is topography enough? And I come with this first example that topography may be with inferior stiffening, and we have a TBI, which is normal, also a thick epithelium inferiorly, which is not displayed here, but this patient has warpage. So the improvements that we have going beyond topography is unquestionable. A lot of people would say topography is not necessary, but in this patient that came as a refractive candidate because of contact lens intolerance, the patient has very easily seen a superficial keratitis and a tear film that is irregular, and this can also be seen in the ocular scatter index with the Rogers Aldivar work. Very nice work on the tear breakup time at the topography level and also with the ocular wavefront level. This is important also to be integrated with more imaging tools so that you can see the meibomian glands, not the exit of the glands, but the glands themselves. So imaging is important, and we can get the need for posterior imaging unquestionable here. This is not a new case. It's a case from 2003. Came as a keratoconus evaluation, and the patient does not have keratoconus. The slit lamp, you have matte dot fingerprints, and you can correlate the placido reflection with this. So topography is necessary, and placido disc is still around, but this is an evolving field, and we need to go beyond but not over. I was fortunate to do my training with Steve Wilson, and when I was going to my fellowship, I remember seeing coming across this review that in the future we would see very nice improvements from topography and customized treatments based on topography, that all of these names, Helmholtz, Placido, and Glustrand will be impressed. So a few years later, I was finishing my fellowship, and with Steve Kleiss, we also published the topography and pachymetric screening. About 1% of patients that have the interest of having refractive surgery, they can come with these abnormalities, and most of them can come with normal distance vision correction and normal slit lamp. So we have to be keen to interpret those cases. Of course, scales are very important, and this pellucid light is not exactly enough for us to give the diagnosis of pellucid. We have to look at the slit lamp, and we also can look at this slit lamp along with Scheinfeld imaging, with OCT imaging and tomography, which is going to be the detection of the thinning pattern so that we can classify ectasia. So in this case, you have a false pellucid, inferior keratoconus, and in this case, you have a true pellucid, which is related to the thinning down below, this band of thinning without opacity. It's important not only for academic reasons, but for the treatment and for the prognostic factors of these patients. Nice work by Juan Carlos Abad on a different shape that we can have an ectasia. The D's which can be correlated with front and back elevation abnormalities in patients that eventually had laser vision correction and had ectasia. When you think about ectasia risk, we have to go in the literature, and we came across the great contribution by Randleman and collaborators since he was in Emory, since his residency and fellowship, he has been a nice prolific worker on this area, and we have the topography in the top of the list. And the nice contribution is that it integrates other parameters like age, which is a surrogate of corneal biomechanics. We also have the residual stromal bed that Marconi Santiago has improved to the percentage of tissue altered, and this is going to be integrated with the impact from the procedure and how the cornea can be reliant so that the cornea can afford or not this weakening. Interestingly, the topographic patterns, you have foam fruits keratoconus as a synonym for abnormal topography. And we have normal symmetric foci, asymmetric foci, the skew radial axis, and the inferior stiffening. And I think this is misleading to understand foam fruits keratoconus as an abnormal pattern on corneal topography. The progressive iatrogenic ectasia was first described after LASIK in 1998. The first case was a series of 3 cases that had LASIK for high myopia. A few months later, Bill Seiler also published iatrogenic ectasia in a foam fruits keratoconus, and you see this foam fruits will be classified as inferior stiffening if you have the classification. But those 2 cases, the 2 reports, the first reports of ectasia after LASIK are related to the pathophysiology of LASIK ectasia. Actually, the pathophysiology of ectasia itself, which is related to the corneal resistance, the innate biomechanical properties, and the impact from the environment. And of course, laser vision correction weaken the cornea, but eye rubbing do weaken much more. The major concept is that any cornea may develop ectasia, and eventually, if you want to avoid ectasia, the first very important thing is to tell people not to rub the eye, not to scratch the eye, not to sleep over the eye, because it can aggravate keratoconus and even cause ectasia. Those are 2 different things. And if you understand the aggravation of keratoconus and the causing ectasia as 2 different things, I think is a major step forward to understanding the pathophysiology. Nice work by Steve Schallhorn with over 300,000 LASIK procedures. He has ectasia, actually, in the ectasia group, 30% had a normal pattern on topography and tomography, and 1% of the stable LASIK cases with over 4 years of follow-up may have abnormalities. It's important to understand what is foam fruits keratoconus. Foam fruits keratoconus is not exclusive from ophthalmology. We have foam fruits diseases in medicine like psychosis, but Mark Hensler was the first coined the concept of foam fruits, first on Javal, and later on the nice work on the follow-up of patients with Polaroid photokeratoscopic from the placido disc. Yaron Rabinovich would say, though, that foam fruits keratoconus is a patient with abnormal topography that has a normal slit lamp and normal direct vision. But the fellow eye of this patient, as according to Kleist, would be the foam fruits, sometimes calling as unilateral. This would be the very asymmetric cases that we learned from tremendously. And I know David has done many work on the tomography of these fellow eyes with normal topography. A very nice contribution from Damian Gatinel is that we understand the topographic criterion, and here almost we have a sharp edge. So we have a normality and keratoconus, and we have suspect and the fruits. I do believe it's a great way of looking at that. The fruits typically have a normal topography. So foam fruits, in my opinion, is like this. Those are the susceptible cases, and those are not irregular suspicious topography. And the subclinical keratoconus are the cases that we want to detect because those are the ones that have high risk for ectasia after laser vision correction. A very nice systematic review by Luis Izquierdo and Maria Enriquez from Peru found in the literature a huge variability, which goes in agreement with the lack of consensus that we had in the global consensus. And my contribution, my humble contribution that I quote is that foam fruits keratoconus should be defined not as a topographic classification, but a cornea with high susceptibility for ectasia progression. And the colleagues from the Refractive Surgery Alliance, for example, they would say it's a great way of putting the name because words matter, and keratoconus and ectasia susceptibility are not the same thing. Interestingly, in 2008, we have this paper accepted at the AAO, Tomography and Biomechanics, for detecting ectasia and its susceptibility. In the same year, I debated with Doug Koch because elevation and curvature were the kind of being opposite to each other, but they are definitely complementary to each other. And Doug Koch presented this case in his Cornea Day debate on defending curvature, that this will be like a pathognomonic sign of irregular astigmatism and form fruit keratoconus. This case helped me to see the need for looking at the variability of subjective classifications. Nice work by Isaac Ramos. This case was case number 6. And we first sent the topographies, 25 cases for experts, and the mode was 0 with the first 1.5 diopter scale, the absolute scale by Smollett and Kleiss. And a few months later, we sent the same cases to the same experts, and we have the mode still being 0, but varying from 0 to 4 with a 0.5 normative scale. It's important to see that we have to go beyond but not over, as we put in this editorial with Brad Runderman, that we have to go beyond but not over detecting keratoconus and looking at the front surface cornea topography. We want to evolve to the understanding and the characterization of ectasia susceptibility, which I refer to as enhanced screening. So corneal topography with a P evolved to corneal tomography with an M. And it's important to understand that tomography is not new. Tomography was first introduced in 1998. And during my residency, we received the Orbscan 1, which has horizontal lens scanning. And I started the work during my residency to look at the orb cone in 1999. And this picture was very important for me because it gave me the idea of looking at the thickness profile, which took me a few years to start this project. But at this time, in 1999, we were already looking at very asymmetric ectasia cases in which you have a normal topography in one of the eyes and trying to see if we find anything abnormal on the tomographic level. I did my fellowship with Steve Wilson that wrote this very important editorial in ophthalmology on cautious regarding the measurements of posterior corneal curvature. Wilson is also one of the most important leaders in corneal wound healing response. And I would say that this case made the point that we have to go beyond but not over. It's not only sensitivity, but specificity. This patient had surgery in 2007, and a few months after his surgery, he had inferior stiffening, progressive inferior stiffening, and he was going to have a corneal ring at that time. And I remember the need for tomography was clear when you see here thickening. And it was a very experienced refractive surgeon that was not keen enough to look at the haze. Of course, here it's obvious, but even him, I say the patient has haze, and I remember, well, there is no haze. And I look at the Scheinflug imaging that he sent me, the U12.5 from the Pentacam at that time, and I say, there is haze. Please take a look and take a picture like this, and here it is. So the haze, the thickening is related to the myofibroblast transformation in which you have thickening from the stroma and epithelial level. So this patient does not have ectasia, and the thickening and the bulging makes a huge point. It would be really interesting to have the OCT or the high frequency ultrasound to see the epithelium behavior here, but the Scheinflug can see the thickening. Scheinflug is a nice principle for photography in which you can put in foci different levels like the epithelium, the stroma, the back of the cornea, and the front and back surface of the lens. This can be seen also at the slit lamp. There's a picture I took at the slit lamp, and you can angulate the slit lamp and the camera so that you can put everything in foci. Interestingly, I think it's important to mention that Julien Carpentier was the first to describe in 1901. He was actually cited, quoted in the patent from Theodor Scheinflug, who has most of the recognition today. But tomography means to cut a slice of the cornea and you have a 3D reconstruction with front and back surface of the cornea. But it's not only the corneal tomography, it's corneal tomography in anterior segment. And the shine field tomography is the most common way. Most of the instruments do rotation shine field imaging, but the Orbiscan still do the horizontal scanning, and we have a very nice system, the VX130, which is a company from Israel that has a up and down, which I don't have experience with, but it's a very interesting way of looking at the shine field imaging as well. It's important to mention that it goes beyond the cornea, and we can correlate shine field tomography and shine field image of the lens with whole eye wavefront and corneal and whole eye wavefront and phacoemulsification parameters for cataract surgery. So we can say that shine field imaging can tell you how and when to do cataract surgery. Tomography can go beyond to OCT and high frequency ultrasound. We have this opening the door for segmental and layered tomography, which we have seen first with the high frequency ultrasound, nice work by our friend and colleague Dan Weinstein from London, in which you can correlate the epithelial thinning with thickening around the area of thinning that tries to mask the cone, because there is stromal bulging and thinning as well. Also, of course, the epithelial mapping came to be more popularized when you have the OCT work by David Huang and Yan Li, in which you can see a very nice epithelial mapping, and we have done it since 2013, and it really opens the door for a new horizon for understanding corneal imaging. So we published the role of epithelial thickness for keratoconus and keratorefractive surgery, also for therapeutic procedures to understand the late epithelial hyperplasia after corneal ring segments. But the fellow eye of a patient that has keratoconus in the other eye or asymmetric ectasia, this is a thinning that you see, and you have the thinning getting worse and worse in different cases with more pronounced. So this is axial topography with the shine field. This is front surface elevation. This is elevation, and then this is OCT data with whole eye pachymetry and epithelial thickness, and you can see the change in the epithelium. This is related to multimodal imaging, and multimodal imaging can be integrated on the Pentacam. The Pentacam, I first started working with the Pentacam in 2003 and 2004. I received the first one. The HR, which is a more advanced camera with higher definition. We have the AXL, and also today the AXL integrated with a Hartmann-Shack sensor for whole eye wavefront data, which is the same machine that we have available in the Alcon platform for the site map. And this is going to be evolving for the diagnostic and for planning. And interestingly, we have to understand the data. One of the nice ways of looking at the data is with the histograms. So we have disease and no disease for different situations, like angle closure glaucoma, and you can see how the patient is behaving in terms of the condition they have. Interestingly, when we talk about ectasia, we discussed the Belling Ambrosio, which combines the nice work by Michael Belling on elevation, front and back, the thickness profile that I described, and we have a deviation from normality with the D. Michael also did a very nice contribution, the Belling ABCD progression display, in which you see the threshold for looking at the significance of change from a baseline. So this is going to be related to repeatability on the keratoconic population. So you see front and back curvature at the thinnest point, and here you have this is vision correction. When you think about elevation, I think it's a very important concept that we have to get is elevation is a subtraction map. Subtraction from the cornea that was measured and a reference shape. And this very nice cartoon from Damien Gatineau will give you a way of looking at the subtraction that can be from a basket sphere or toric ellipsoid. You can do float. You can change the zone for calculation. And eventually, the zone for calculation change tremendously the reference. So a steeper cornea will have a radii that is lower than the reference. So you see this is depressed considering the elevation, which is the opposite of the hot colors that you see on the axial maps. So here we have astigmatism, and here you have the pattern of ectasia, in which the astigmatism is not going to be described, and you have an island or a peninsula of elevation. These are the same front surface curvature elevation maps from the same cornea. The change is the zone for the calculation of the best fit sphere. I recommend to use 8, but here we have 9, and here we go to 12. So going to 12, you have more data that are lower in elevation, which goes in the average, and the average would exacerbate the area in the center. So keeping the same best fit sphere zone to calculate the best fit sphere is recommended. And another concept is best fit sphere and toric ellipsoid. I have seen for many years a debate by Michael Bellin and Jack Holliday on the best fit sphere and toric ellipsoid. And in 2010, we put together this poster for the cornea waveform for the Cornea Congress. And this is comparing best fit sphere and toric ellipsoid, the metrics, and the ROC curves are pretty much the same. This is for normals versus keratoconus. Interestingly, if you see, the cutoff values are much different. They have the same accuracy, but the cutoff values are much different. And you see best fit sphere and toric ellipsoid changing the pattern recognition will be easier to see in the best fit sphere. Toric ellipsoid can be very sensitive as best fit sphere, but in the Pentacam, the change important that you have to be clinically significant is on the elevation thresholds. The enhanced best fit sphere concept by Michael Bellin is a very nice one, in which you have an exclusion zone, and if you have a change, this change means that this exclusion zone has a protrusion, and this can be looked at the standard, the enhanced, and the subtraction of those two, and eventually you have the green, yellow, and red reference scales. My way of looking at corneal tomography is more simplistic, so you get the thickness profile. This is the first day I used the Pentacam, and I can tell you that since the first day I got value from the Pentacam. This patient was going to have LASIK, and from the Pentacam map, we got the information that the cornea was thinner than 500, and with the ultrasound, I could detect less than 500 here down below, and this patient had PRK. But the thickness profile is more important, the pachymetric distribution, which was a hypothesis that I started doing my residency, and the thinning as a hallmark of ectasia can be a very nice description for ectasia as a disease. So we didn't know about this paper, this very important paper, a classic one from 1969 from Mandel and Post, in which with a pachymetry, optical pachymetry in the horizontal axis, you can see the difference between the periphery and the center, very much abnormal in the keratoconus population. So we have tomography, so we can go 360 degrees on the thickness profile, so that we have the average of the circles with the center at the thinnest point, starting at the thinnest point, and this is the pachymetric increase considering the thinnest point, starting from 0%. When you think about the ectasia conundrum, we go back to the case that Coe presented. This is part of a series of patients that we have the pre-op values of the Pentacam data. And this patient had a BAD-D of higher than 2, which along with Artmax will detect ectasia susceptibility. This is not the end of the story. We have other examples that we can say. For example, this is SMILE case that developed ectasia. I got the U12 files from the pre-op from my colleague El Nagar from Egypt, and he got ectasia susceptibility very nicely, as this is actually a keratoconus with a low K. In fact, 10% of clinical keratoconus have a lower than 46 Kmax. This is clinical keratoconus. This is low K keratoconus, and they can be classified as keratoconus based on slit lamp, based on the clinical picture, and also on topometric data. And if you want to have cutoff values and sensitivities, this table can be, that was published in JCRS, very welcome. What about specificity? Specificity is the ability to say that the patient does not have the disease. So we go back to the retrospective studies on patients that have abnormal topography. This patient had LASIK in 2008 and had a very stable case, actually more than 10 years follow-up. I talked to the surgeon a few years ago, and patient has stability very well documented over 10 years. And the pre-op evaluation of tomography would enhance the specificity. Actually, this was not taken into consideration. The patient had LASIK based on the age and the thickness of the patient. A study that looked at 3,278 LASIK cases, stable cases versus 105 ectasia cases. You see the IS value very specific because the surgeons, they do pay attention on that. But the D, which was not considered when these patients were operated, had a sensitivity and a specificity that are not optimal. So we need to go and understand some concepts and the very nice work on integrating AI for disease and no disease, and including the disease, the very asymmetric ectasia cases, and some of the cases that we had the pre-op data from tomography, we were able to enhance with the Pentacam random forest, improving the sensitivity and the specificity beyond the D score. This was published in the AJO a few years ago, but we still have cases down here. And for that, we need to go for biomechanics. Biomechanics is being studied for many years, and as quoted by my colleague and friend Canrobel Oliveira, this is an exam from the past that never existed. Cynthia Roberts and BJ Dukes have done tremendous work in this area to acknowledge the importance and eventually to do some clinical testing. Today, we have the Corvus ST, which gives us as a non-contact tonometry in 31 milliseconds, 140 frames, and we have a lot of data that can be integrated with artificial intelligence, so judicial regression analysis with the CBI, and this is a nice work by Ricardo and Paulo Vinciguerra that got the Troutman Award a few years ago. And we can separate a softer cornea and a stiffer cornea. Integrating tomography and biomechanics is the report that we have with the random forest leave on out cross validation as the TBI. So this is a work that we collaborated with Italy, and we got patients with normal topography based on a strict criteria, 94 cases. This is one eye randomly selected for 480 cases, 204 keratoconus, one eye randomly selected, and 72 fellow eyes with ectasia that had not had surgery from these cases. So we see this is an epitome for ectasia susceptibility as our understanding, with a very nice separation for the clinical ectasia cases and decreasing the threshold, we have 90.4% sensitivity. Important to understand that some of these cases may have unilateral ectasia, as this one that had the ring, and he was followed by Dan Ringstein. Everything was normal in the very prolific exams that Dan does, including the score analyzer by Damien Gatinel and Alain Saad. And retrospectively, the first exam in 2014, we had a normal TBI, and in a few years later, we still had a normal tomography and biomechanics. So it's a true unilateral ectasia case that we reported in the International Journal of Keratoconus and Ectatic Disease that is nicely published by my colleague and friend Adele Barbara. This goes in agreement with the concept that true unilateral keratoconus does not exist, but unilateral ectasia can occur due to a purely mechanical process. Interestingly, foam-fused keratoconus or ectasia susceptibility can occur in both eyes of the same patient, and it's the best example I can show you. We have one twin sister with asymmetric keratoconus. This is topography from placido disc. This is the topometric from the Pentacam, and we have exactly the same appearance on the axial curvature maps. The TBI is abnormal in all the four eyes, including both eyes of the twin sister that did not rub the eye. Interestingly, the Avagen from Avellino would detect ectasia susceptibility, and I do believe it's very important to look at this as a new possibility for opening more understanding in ectasia susceptibility. A couple of examples here. This patient came as a refractive candidate. You see asymmetric ectasia on topography. You can detect abnormality. This is the case that makes the point that topography should be done for every patient, and tomography here is not very abnormal. So elevation is borderline. The bad D score is borderline, is not even borderline, can be a little bit susceptible, but when we integrate with tomography and biomechanics, you have 0.64. But this patient is a patient that has lens dysfunction. And Scheinfeld can tell you about the lens. So this patient, along with the lens dysfunction, can be characterized. And I told this patient not to do any surgery because he's still seeing very well with high contrast vision. But soon, as he loses contrast, I'll go for the stage 3 with mild cataract. And with this type of documentation, I'll be accepting to do surgery in him for removing the cataract. Another situation, 72 years old with 20/30, she's doing well with her glasses, but you see some spikes on the retroillumination, which can be nicely seen on the level of the Hartmann-Shack sensors. And interestingly, this patient has a high peak in the endothelium. You see this high peak in the endothelium, the corneal densitometry, the back of the cornea is correlated with guttae. So this patient, I told her, you should do surgery as soon as possible, because as long as you wait more, the lens is getting stiffer, and I will need more energy to remove your lens, and eventually your cataract surgery will lead to more corneal endothelial issues. Interestingly, this patient has also abnormalities on the TBI, and here is not calculated because of some of the quality factors in the right eye, but you can see that this patient has a combination of guttae and keratoconus, which we also published in the International Journal. Interestingly, importance of screening for ectatic disease prior to multifocal IOL is clear. We have seen many of the cases unhappy with cataract surgery with multifocal IOLs because of subclinical fluid keratoconus, and we need to screen for that. We also have to screen for subclinical edema. Subclinical edema can be seen on tomography. Very nice work by the colleagues led by Dr. Patel from the Mayo Clinic, in which you can see the displacement at thinnest point, the loss of the parallel circle oval isopax, and the depression on the back surface of the cornea. Here you can pay attention to the scale that they use. I prefer to use a scale that is called blue for the depression. So we have blue on blue and red in red for ectasia, as described by Paulo Vinciguerra. So blue on blue, you see the depression, you see the change, and also you can correlate all of this with the OCT, and the thickening of the Descemet's complex is a very important parameter for prognosis in Fuchs district. Nice work by Shizuka Ko on the understanding of tomography and biomechanics prior to cataract surgery in the University Hospital. I'll come with a final example for you. So this final example is a patient, 13 years old, very recent patient. Saw this patient last week for the second time, and he presented with keratoconus in the left eye and everything normal in the right eye. So you here with the two scales, this is Ambrosio 2 scale, this is the Atlas scale, which is very popular in the United States, with a half diopter absolute scale. And this, why this exams can help you, how advanced image can help. First, in the right eye, you can say that the right eye is a form through keratoconus or a susceptible cornea. The patient is doing very well, but still don't need to do anything, just to follow up. Also, the exam not only confirms ectasia in the right eye, ectasia susceptibility of fluid ectasia, but in the left eye, you see here not only the 13 years old, but the low biomechanical, the stiffness parameter from Cynthia Roberts at the first applanation time is a very important indicator of prognosis. So indicate right risk of progression. And the patient comes back. This patient is very interesting because Kmax actually decreased. But if you see the subtraction map, the B minus D, you see curvature increase here. So Kmax decreased, but you see a little thicker red here than here. And interestingly, in the Bellin ABC, you can see the A and B, important change, and this patient has an unquestionable progression. Actually, he lost also distance correct vision. So this is unquestionable need for cross-linking in the left eye. I do believe that ectasia should be treated as soon as possible when surgery is needed, and cross-linking is not for every patient, but when you need, you should do it as soon as possible. So corneal imaging for refractive surgeon, we have to understand what we are trying to achieve and how. We have a lot of work to do in terms of how to use the technology. We have topography as being very sensitive to detect mild keratoconus, and for clinical follow-up, the need to go beyond is unquestionable, and we have to go beyond and beyond beyond tomography to biomechanics with Scheinflug, segmental tomography, and corneal biomechanics. We have to face the limitations of objective versus subjective interpretation. Astigmatism characterization, we have the front surface of the cornea, the back surface of the cornea, the thickness, and the total corneal astigmatism, very important for everything since planning contour treatment for topo-guided treatment or any other platform, and even toric IOLs and planning for premium IOLs for cataract surgery. Of course, planning and evaluating post-op results objectively would lead us to more objective data to further titrate and improve the outcomes, and the relevance of the tear film should never be forgotten. So thank you very much for your kind attention, and look forward to these sessions.
Renato, thanks a lot. Was a fantastic lecture as usual, and always learn a lot. And it's apparently new version of the Pentacam will fit any type of clinic, and not only the refractive clinic anymore. It's a really huge
Multimodal.
variety of multimodal. So I think, Avi, you had some question for Renato. And guys in the audience, if you have any question, please feel free to write your question, and we'll make sure Renato could answer.
Yes, Renato, thank you very much for this great lecture. And here in this country, we have been using the Pentacam system for quite a while now. I think the Pentacam system is very well used, and all over the country, in most of the centers, we have the Pentacam, and we use the Bailey and Ambrosio enhanced Hadassah display. And it looks to me, looking at many cases that are refractive candidates, that the evaluation system that you call the enhanced Hadassah display somehow disregards the corneal asymmetry. You know, shifting from the old system, the placido disc system, where we used to look at the patient that has an inferior steepening, and we used to faint and say this is a keratoconus suspect, and then going into the elevation concepts where the inferior steepening was not so well introduced into this system. Somehow we believe that the corneal asymmetry was neglected in your evaluation system. And we have many cases where, and I can show you many cases, some cases also, where there is a significant asymmetry of the cornea, a significant inferior steepening or asymmetric bow tie. And the other systems, such as the Galilei, detect it as an abnormal cornea, but the Bailey and Ambrosio display looks at it as a completely normal cornea with a normal final D. And although maybe the PTI, the progression thickness increase, somehow factors in this asymmetry, I think that you should, you know, somehow look into this asymmetry also and find a way to factor this into your evaluation system.
You're absolutely correct. The Pentacam random forest index includes some curvature metrics, and they go exactly where you say on the asymmetry. Another very important factor when you say asymmetry, you have asymmetry between the temporal and nasal, superior and inferior parts of the cornea, and between right and left. If you see the first keratoconus criteria from Yaron Rabinovitz in the late 80s, he described the fellow eye asymmetry with one diopter as a very important factor. So asymmetry is very important, and not only in the same eye, but within the eyes. And the idea is, you're right, the first display is based on elevation and thickness profile. It does not take into consideration the curvature. But I think we have to face the point that is beyond but not over. We should not neglect curvature. We should not forgive the placido. and eventually integrate all the data so that we have multimodal imaging for getting the data for helping the patients the best way as possible. But I know about the patients that you talk about, and we are very aware. If you see the ectasia susceptibility study, you have about 35 to 40% of the patients pre-op LASIK that had ectasia with a normal D score. But in fact, only 25% have abnormal asymmetric astigmatism, like the IS value. So IS value is important, is not the only thing, but definitely should not be neglected. The concept is beyond, but not over.
So would you suggest to the, normal refractive surgeon to use more than one imaging system in order to, account for as many factors for ectasia screening as possible? For instance,
Uh,
if you use both Pentacam and the Galilei, would that
uh,
cover more aspects of
you,
ectasia?
you can use the Galilei and the Pentacam. I think if it fits in your practice well, it's very welcome. I use in my practice the placido disc topography. I use a whole eye wavefront data along with the Pentacam and the Corvis, which is biomechanics. But if you ask me in terms of the best accuracy for ectasia detection, the combination of Pentacam and Corvis will be the way to go.
Okay, thank you.
So Renato, I think regarding the asymmetry, I think we have a question from Dr. Solkin asking about the BFS and BFTE for refractive screening. It's actually interesting because we did publish with Ron a couple of years ago on the Galilei, and we find the BFTA very interesting to highlight the asymmetry component of the cornea. Do you think that in the Pentacam you can also take profit of the BFTE for the same thing, or you think it's less sensitive for?
No, it's a very good point. The best fit toric ellipsoid gives you irregular astigmatism. When you fit in a nice toric ellipsoid, you fit perfect astigmatism if the astigmatism is regular. So everything that is irregular astigmatism will be highlighted in the toric ellipsoid. What I say is that if you have a keratoconus elevation map with a best fit sphere and a toric ellipsoid, the best fit sphere, the colors will be more pronounced. But we did an enhancing system for the TBI, very recent work. So we have the first study, 94 cases, very asymmetric ectasia, and now we expanded it to a multi-center study with 540 plus cases with very symmetric ectasia. And one of the parameters that we included was the best fit toric ellipsoid elevation at the thinnest point. So it comes to be important, but other metrics for the whole eye, for the corneal wavefront, will be probably better than the toric ellipsoid data. But I would say that probably this has to be taken into consideration that it may be instrument dependent. Some instrument may be changing the algorithms for the calculation of best fit toric ellipsoid. And of course, clinical studies have to be done. The best is to do the clinical studies, ROC core curves, and seeing the accuracy in a comparison way.
By the way, the BFTA, are you leaving the BFTA with fixed or the BFTA with float on your studies?
We prefer to use float. We use the float. We use the float because it tries to fix. If you fix, what we fix is the 8 millimeter zone. But if you do the float, we get a better sense of how this cornea is behaving for irregular astigmatism description. But eventually, we can test different ways.
I have another question to Renato. Again, using the ectasia display, we have this 4 figures of a standard deviation or the lower part of the paddle and the big D, the final D. And I was always intrigued as to the relative contribution of each of these figures in the big D. I don't know if this is a secret, but what is the relative importance of the elevation profiles compared to the thickness profiles? And also, don't you think that the thickness profiles are somehow giving you the same kind of information? Because if you use the thickness and the ART, it looks like this is a redundant information that you use it several times in order to create the big D.
The big D, we have some cases that the art max is lower than 480, which is my threshold, and the big D is lower than the 1.2. So those cases made the point that you can have a low art max and a normal D. We have cases like that. The combination of data is the way to go. The D was developed 10 years ago, exactly 10 years ago. So we should use the Pentacam random forest, and I hope to have this display soon in the Pentacam for commercial use. But even myself, when I receive a Pentacam, I have to do a little calculation. It takes me a few clicks for getting the Pentacam random forest index for using in my clinical practice. But it comes very easily if you have a Pentacam plus the Corvus for the artificial intelligence integration. But the final formula is published in Michael Belling's book on elevation, cornea elevation. So it's not a secret, but it wouldn't work for any other instrument because that's really going to be very specific to the instrument. But it's not difficult to develop a formula like that. It's just using linear regression. But when I talk about that, I think about the whole concept of evolution that I had in terms of even myself when I started looking at that, learning what are the ROC curves, learning what is a linear regression analysis, and what is truly artificial intelligence that we can do with neural networks and random forests, and that's much more sophisticated. So I would say linear regression, they have some limitations for that. So you have a multi-dimensional way of looking at the data, and the artificial intelligence is definitely here for helping us on that.
But would you think that, can you say that the elevation profiles are the same, have the same contribution like the thickness profiles, or which is more important?
The thickness profile has a little bigger weight on the linear regression, but at the end, if you get linear regression analysis just averaging all the parameters, you have a very high accuracy. So eventually, if you ask me which formula is today in the bad D, I have a few slides that I have to go back, and I don't think it's so important to know which formula it is. I would just say this is a better parameter, but it's not a perfect parameter. And we have also getting better and better with random forest for Pentacam and Pentacam plus Corvus. And if you go to the OCT domain, you probably can get even further better. One nice last word about genetics. I think it's if you have a patient with ectasia after LASIK, and the first thing I will ask, do you have a Pentacam pre-op? If you have a Pentacam pre-op, please send the U12 files to me so that I can analyze. Oh, you don't have. But the genetics are not going to change. The genes of the patient, they don't change with LASIK. So it's a huge opportunity we have for doing genetic studies on patients that had LASIK ectasia, because you don't need the pre-op data. You just get the patient genes now, and eventually you can do the studies. So this is something that we should all think about, and eventually the genetics will be more and more important for us because of that.
Renato, let me ask you something that is related to genetics. I moved from France to Israel, as you know, and there is a huge difference in terms of corneal thickness between population. Now, France is mostly Caucasian people. So corneal thickness is on average 520, 530, and we published 10 years ago comparison between North African cornea and Caucasian cornea from France. Now I moved to Israel, which is pure Middle East cornea. And Israel, it's a very interesting society because we have here people from Iraq, people from Egypt, people from Yemen, and those patients, Morocco, and those population has a very thin cornea as compared to Caucasian one. Now it's interesting because they do not seem to have any other abnormality in terms of curvature or elevation or asymmetry. But I was thinking because of the huge spread of the Pentacam device, that would be fantastic. And you know that having a new index means that you have to get your study population. Now that would be great to have according to the area of your work, just to select the cutoff according to the area where you are working. For instance, if you are working in the Middle East and you have the Pentacam, you just have to click Middle East and it adjusts according to the superpopulation of patient from Middle East. So same thing for Asian. Do you think it's something feasible in terms of?
I've been dreaming with this display for a long time. Actually, we have a publication from an international Pentacam study, and it can be even very interesting. We have in Brazil, in São Paulo, we have the largest number of Japanese people outside of Japan than any other place. They moved to Brazil 60 years ago, and some of the families are purely Japanese. They don't have, we have a lot of mixture, but we have pure Japanese people in the second and third and fourth generation. And interestingly, we have a trend to say that the Japanese from Japan have a thinner cornea than the Japanese from Brazil, but I still need to have clinical scientific data to say like this, but it's like the genes and the environment. And in Brazil, we have the average central corneal thickness is 540. In the United States, in Seattle, we did it was 555, which is the same as Indianapolis. So and if you see there are some huge changes from population to population in the thickness, and it also changes on the elevation and on some curvature metrics as well. So the bell-shaped curves are not so separated like in keratoconus versus normals, but what is a normal in China is different than the normal in Japan, what is a normal in Europe, and of course. So it's definitely a good point, and I hope to have clinical data for not only Pentacam data, but also biomechanical data as well for different populations. And we have, for example, for China, which is a huge demand on the market, we have now a CDI that has been developed for improving the accuracy in China, and it really works. And I really like this concept of titrating for populations.
That's great. I look forward to have that for Middle East because it's was scary at the beginning to do surgery on 480 cornea. And when I see that 40% of my patient has between 480 and 500, I say, well, it seems to be our normal population here.
Yeah, I have same thing here in Brazil. And if you go to India, it's even worse. India and other places that are more prone to have thinner corneas.
So I think last question here from one of our residents. I think you're gonna like this question. It's about the form-first definition. It's obviously a resident's question to talk about definition. If form-first is not topographic, I'm reading the question. If form-first is not a topographic disease, but a susceptibility to have ectasia. So there is an age limit to diagnose from first, because we know that ectasia is much rare in older patients.
That's a great question. Very good thinking, but we'll open the mind of our colleague to think about that age is a surrogate of corneal biomechanics. And I even did that in artificial intelligence work. We played with age and tomography, and age was part of the algorithm. When we include biomechanics, the artificial intelligence methods throw out what is not going to be useful. So age is excluded for the algorithm. So age is going to be important if you don't have corneal biomechanics. But I can show you some examples of patients with 17 years old that are very strong corneas, and some patients with 45 years old with weak corneas. So in the same person, aging is going to be a factor for the natural cross-linking, but not in everybody. So we can have young patients with strong corneas and older patients with weak corneas. Corneal biomechanics is definitely a must for understanding that.
Thanks, Renato. So that was fantastic. That was great that we had the chance to discuss with you also and to ask many of the practical questions with the master. So that was really great. Renato, thanks a lot.
Thank you.
And I think
My
we can move forward with Ron lectures now. Ron, can you share your screen? If you have the possibilities.
Okay, I'm going to do that. Okay, do you guys see it?
Yeah, very good.
All right, good. I will go ahead and get started. So thank you. I don't know if you see any of the other stuff on top. Let me scroll this down a little bit. Okay. Okay, let me go ahead and get started. So being that this is a refractive surgery basics course, I thought it'd be good to give some sort of a basic lecture on ectasia screening with Pentacam versus other methods. And the real focus, I think, of this session is Pentacam. And so we have the master with Renato Ambrosio of Pentacam, who just gave you that great talk. I'm going to kind of drill down a little bit more on some concepts leading up to that, other devices, how to sort of make sense of it, and hopefully that'll be an overarching thing that'll sort of complement some of the things that Renato already talked about. I am from the Trulson Eye Institute of the University of Nebraska Medical Center, and I have no financial interest in topography or tomography. So really, when we think about keratoconus risk with refractive surgery, it's really a matter of biomechanics and the effect of biomechanics overall. And the best way for us to really get a sense of how stiff the cornea is by looking at shape, by doing a clinical exam, by looking at a topography or tomography, and then ultimately having a scoring system by which we know what is safe and what is not safe, and coming up with metrics or indices. And there's countless indices that are out there, almost so much like an alphabet soup, where you just kind of get confused about really what's the best to look at. And most of us as refractive surgeons are looking and saying, where do we go? How do we make a quick evaluation? We don't want to spend 20 minutes looking at 10 different indices. We just want to get something that's going to tell us it's okay or it's not okay to proceed. And with corneal ectasia, it's really a progressive weakening of that collagen lamellae. So that structure that we're looking at, that curvature or whatever it is, has to do with the function of the collagen that's underneath it. And that function is really hard to understand and know. And that's why it's been so challenging. Add to all of that the fact that laser vision correction cuts and ablates the corneal lamellae And the strongest corneal lamellae happen to be the ones near the front surface, the front 40% or so. And so we need to really carefully screen out at-risk eyes, because we don't want to contribute to the process of ectasia in somebody that otherwise might have been on the borderline and, you know, maybe never progressed had we not done surgery. So we have to really look for metrics that screens this out. And there really is a difference. When we're talking about Pentacam, there's the difference between screening for risk of post-LASIK ectasia and monitoring progression in keratoconus for cross-linking. So Pentacam gives you both indices. In fact, this next slide kind of shows a little bit about staging keratoconus and looking for progression to know when to cross-link. And it looks at certain metrics such as the anterior curvature, it grades that, it grades the posterior curvature, it grades the thinnest pachymetry, and it even grades the best corrected visual acuity, which you can then punch in. And then from that, it looks at all of those to say, how is that changing over time? And once you know that it is changing over time, then you can say, well, this patient is progressing, and therefore it might be sound and reasonable to say, let's stop the progression with cross-linking. Of course, keratoconus comes in different stages, and that have to do with front and back surface, curvature, and the thinnest pack and the vision. And that's why this is an important metric. But really what we're talking about is screening for post-LASIK ectasia, which is much more sensitive, because it doesn't necessarily mean these are abnormal eyes, but they may be abnormal eyes for the sake of doing vision correction surgery, because we don't want to do something surgically on somebody that is otherwise at risk. And so what have we done in the past with that? What are we doing now in the present? And what might we be doing in the future to help screen out these eyes? So in the past, it really was a matter of topography, age, and depth. And pre-op topography has kind of been the gold standard for a long, long time. We're modifying it by looking at tomography and looking at other metrics, but without a topographer, you can't do refractive surgery because you just don't know what you're dealing with. It's really finding the tip of the iceberg, which is what we see, this little tip on the top that says, hey, something's abnormal. Meanwhile, there's a gigantic abnormality underneath the water, which we really want to seek to understand better. So is the topography normal? And the way I usually look at it in terms of steps is, number one is rule out any kind of artificially created surface problems, such as contact lens warpage or an ocular surface abnormality like dry eyes. And you have to actually look at the placido rings to see that there's a great signal there to make sense of that, and make sure that that patient's out of contact lenses for a long enough period of time so that you're not calling something potential keratoconus that really is just a warpage of the eye. Then there's calculating the IS ratio, or inferior to superior ratio, and I'll go over some of that. Looking for skewed radial axis, which has to do with a non-orthogonal level of astigmatism. Determining the steepest K reading, because if corneas are very steep, even if they're very central, something might not be right there. Of course, looking at topography change over time. If you can see progressive change in topography, that's a big red flag to be looking at. And then we get into our advanced imaging methods, which have to do with elevation maps and tomography, which is really a focus of some of this later talk. So contact lens warpage, it's usually soft contact lenses out for 3 to 14 days, rigid ones for about 3 weeks or 2 to 3 weeks. And when in doubt, if somebody's been using contact lenses, especially rigid ones, for a long, long time, you might want to even stay out a whole month for every decade of use, which can be an extremely long period of time to let things normalize. Of course, with ocular surface, you want to make sure that tear film is very healthy and normal and deal with any ocular surface disease. With the IS ratio, I think it's good just to understand how this is calculated. You know, they actually take a 3 millimeter diameter centered on the corneal topography, and then they look at the inferior most and superior most, and then additional measures that are 30 degrees away in that same radius of that diameter of the 3 millimeters. And so you can see you can get 5 measurements that span this whole area inferiorly and 5 measurements also spanning it superiorly. And then you take the actual K value at each of those, you average that for one single value, inferior versus superior, and then you subtract the superior from the inferior to see what abnormality there is. And if that difference is more than about a 1.5 abnormality, then that's a concerning or suspicious eye in terms of the IS ratio. And in this particular example, which is an obvious keratoconus, you can see there's a 7.1 diopter difference. So it's very dramatic that there's a big difference in this IS ratio, but it's the subtle ones that we want to try to understand better. And that's why this is a useful metric. When looking at skewed radial axis, it has to look at saying, well, where is the axis of astigmatism, centrally as it goes out to the periphery? And then where does the peripheral part of that astigmatism kind of lie in terms of the 360 degrees of angle structures around the eye, and then come up with an angle that shows how much of a skew there's going on. And if you can take 180 degrees, which is our straight line, subtract the A, you should come up with a very low value if it's orthogonal. In this case, it's very non-orthogonal. You got 95 degrees of difference, which is suggesting that even more than 90 degrees is off axis or skewed. And anything more than about 30 degrees of skewed radial axis is more of an abnormal value. Of course, when you look at some of the things that were published back a long time ago, back in the 90s, about different patterns, it's really the skewed radial axis and the asymmetric bow tie with a skewed radial axis that really came out as the most significant in terms of topographic shape. And it turns out that those are the things that are in the Randleman criteria when looking at topography, stromal bedness, residual pachymetry, age, all those factors, and that just an asymmetric bow tie is enough to give a point. But if you have an IS ratio issue or a skewed radial axis or both, that's enough to give 3 points. And that's just one step away from really calling it a formfirst keratoconus. And we know a little bit from the overall scoring that 3 is already very suspicious, but 4 or more do not perform LASIK. At least that was the recommendation that Randleman came up when that first came out as a metric. And we use that as an historic thing that helps us understand where we're at. Some of the thickness issues with regard to Randleman criteria have been modified recently by another Brazilian, Dr. Santiago, who worked with David and myself at the Cleveland Clinic for some time, but which is PTA, or percentage tissue altered, which has to do with your flap thickness and the tissue that was removed divided by the central corneal thickness. And so if that is more than about 40%, it's usually an area of concern. And this was a publication here looking again at that 40%, where they also looked at topographic maps. And they said, if you have eyes that are all are showing some ectasia or have a PTA that's sort of less than 40%, you really don't get any ectasia in those eyes. But if you start having highly suspicious maps, even treating less than 40% might sometimes be at risk. But the 40% cutoff was to say, okay, the topography is more normal, so you can avoid that by trying to stay below 40% in a normal corneal topography. And yet, Renato referred to this with Steve Schallhorn's data, which was a large data set of 300,000 eyes, 199 of them developed ectasia. And this was stuff where they had preoperative information so they could do odds ratio analysis based on the topography and various factors as to which ones developed ectasia. And what they found is that a formfirst keratoconus that maybe just was ignored had a 20-fold increased risk of developing ectasia. The IS ratio or skewed radial axis had all by itself a 5 times risk. Age less than 30 all by itself had a 2.5 greater risk. And then if you start putting that topography together with the age, here you can see a 12-point risk. What was interesting in this study is that he found no correlation with PTA or residual stromal thickness as long as you respected the 250 microns residual stromal bed. which I think kind of puts a lot of question into how thin can you go and how much does thickness bear bear a responsibility in terms of ectasia risk. And yet we still continue to look at it because we know we don't want to be naive in terms of what one particular study showed. So let's go from the past to the present and looking at tomographic indices, which is looking really at front and back surface corneal curvature and radius of curvature and the thickness in between. So it's giving us a whole lot more information, and that more information gives us more power to understand the nature of disease. So what about a subtle topography? And I give you a patient here, which is sort of a little bit questionable. It's a 57-year-old low myope, so not a high correction, older age, so we're not worried about that. There's a lot more stiffening with older age, stable refraction over several years. The central thinnest pachymetry is about 514, so it seems reasonable. And the topography shows a mild, asymmetric bow tie, you could say. Maybe you could give it a score of 1 on the Randleman criteria here, which would otherwise be normal to go ahead and do surgery. Let's see what if we had a tomographic analysis, what would it show us? And this was an old Pentacam because this was a patient from years ago. And we look at it and said, yeah, the Pentacam shows that as well. Look at the back surface, or looks like there's some asymmetry down here, maybe a little elevation here inferiorly, but nothing that looks dramatic just by qualitative appearance. And yet, if you looked at the fellow eye, there's clear abnormality. You can see this area of steepening here that looks much more like a keratoconus. There's posterior elevation, much more significant. It's a thinner cornea and everything. And so you look and say, well, is this just a unilateral keratoconus that some would say is a possibility? But a lot of times you see it in one eye, it's going to be in the other eye. And so how can you better screen out the better looking eye as to whether there is risk or not? Well, we had a Galilei tomographer that we used as well as the Pentacam, and that showed, again, some of this analysis. And with the best fit sphere, again, you can't tell too much from that with the two, although the other one clearly shows the elevation there on the back surface. But when you looked at the best fit toric A sphere, it clearly showed that there was much more of an elevation, even in the better of the two eyes. Here was a 25, which is above the 21 that's recommended as more of a cutoff for normal. And of course, the other eye showed a dramatic example of 88 microns of difference from the highest elevation to the lowest depression, taking out sphericity and toricity on the current corneal curvature on the back surface. So this was actually published by none other than David Smadja with some of our group at the Cleveland Clinic and also in France, and won the Troutman Award in 2013 as the best paper in the Journal of Refractive Surgery. And it was the idea of creating this reference surface for discriminating between normal and subclinical keratoconus type eyes, and even those with keratoconus. And it was subclinical keratoconus was again defined as those eyes which looked kind of normal on one side, but the other eyes clearly showed there was some abnormality. So even the normal looking eye had something subclinical that was going on that we needed to better understand. And that was the point of all this. And just looking at it a little bit more shape-wise, if you take any particular curvature of a cornea and say, let's fit it to this sphere, you'd say, well, there's going to be a certain, you're going to have areas that the best fit sphere is a little above that shape in certain areas and below that shape. But if you can make a toric A sphere, you can match it up to make that above and below differences very minimal, and therefore really drill down on the asymmetric irregularities that can show you the abnormalities of shape. So here you can see again, best fit sphere, you really can't see that there's a little more elevation down below. Best fit toric A sphere, you can see it because you get rid of all the more larger errors of toricity and asphericity. The way this was really calculated is to come up with that overall shape of elevation and say, okay, take the areas that are opposite of each other and then look at the maximum elevation and look at the difference between that and the maximum depression. So in one case, one's a negative value, the other is a positive value. Here's a very large difference of 43, clearly an area of concern. based on random forest sort of analysis, we determined that about 21.5 was enough to be potentially of concern with this AI. And this is all a metric within the Galilei device, which is a competitor to the Pentacam. But the Pentacam was really one of the first, tomography devices out there beside the orb scan that had some really robust optical characteristics. And what I initially showed you with the old Pentacam that didn't really give us metrics, we now have these clear metrics that help us to drill down. And I think it's probably one of the most robust, maybe even better than the Galilei in some ways in terms of its robustness of determining and screening out disease. So the BAD score, or the total D score, is what was being referred to. And it's really a combination of front elevation differences, as you can see here by looking at the center versus the overall, and what is the overall differences. What are the front elevation differences, back elevation differences, the progression index from the center to the periphery, and seeing if that's a rapid change, because that would be a potential concern. The thinnest pachymetry overall, and then the arc-T thickness, the Ambrosio relational thickness, which Renato has so nicely coined and referred to earlier. And it's the combination of all of these and looking at its overall value to say, is it greater than 1.6, which means caution, or is it greater than 3, which means stop? So it's nice to have the stop sign sort of idea. You see yellow, you tend to slow down. You see red, you tend to stop. And that's a little bit of the way I kind of think about it in terms of refractive surgery. So here's a case of a suspicious but normal Pentacam, 30 years old, so not in the 20s, not a very high refractive error, asymmetric bow tie. You can see that would at least give you a 1 on the Randleman score. Thinnest pachymetry, pretty good at 510. Kmax 46.7, not above 47. Is this safe to do LASIK? I sort of ask what does the group think? But let me just go on. If we look at the Bailyn-Ambrosio scoring system, it comes out with a score of 1.39. So 1.39 is normal. It's in the normal range. It's not above 1.6. So this should be okay, but it still looks suspicious. Are we comfortable enough going forward? Well, what if we looked at an additional metric to see if we could make some sense out of it, such as epithelial thickness mapping? And we know that keratoconus as an abnormality in shape causes differences in the epithelial thickness, and the apex of the cone tends to be bulging out a little bit, so it tends to make the epithelium thinner in that location. And so if there was indeed thinning of the epithelium in the area that seems to be elevated on the map, that would be a red flag that maybe this is a form for keratoconus, even though the Pentacam said it was normal. And so we looked at it and it wasn't thinner, it was actually a little bit thicker down below, which says, okay, this is safe to do LASIK, because the epithelial thickness didn't tell us it was hiding an early cone underneath that the Pentacam didn't pick up. It's telling us, no, there is a little bit of warpage here, or a little bit of age-related and also kind of inferior thickening that tends to be seen in some normal eyes that makes it say this is more normal and it's okay to do surgery. So there's different tools that will help us to evaluate candidacy, even with the robustness of the Pentacam. And here just shows a case of the overall normal, where it's a little thicker down below. Here in the case of keratoconus, where you can see there's thinning overall in the thickness of the cornea, because that's where keratoconus is, and there's more massive thinning of the epithelium overlying that area. Here in the case of corneal warpage, you can see what looks like it could be a cone, yet there's thicker epithelium there to say that it's okay. So with that, let me go a little bit into the future. The idea of corneal biomechanics is really the root of the problem, because it's the biomechanics that leads to the shape problems, which is more of a later manifestation. And we want to know more about the root to avoid those kind of form for us scenarios. So ORA was the first biomechanics device that came out. It was really an air puff device used for measuring IOP, but also because it deformed the cornea, could tell us properties about that deformation in terms of the hysteresis. And many of you remember of it, it wasn't as robust as a device as it could have been, but it was the first out there. And it led the way to the Corvus device, which was a video measurement of that actual deformation, which would tell us a lot about the stiffness of the cornea overall, in the overall geometry of the cornea. And that gives us a lot of information that we can then use in a robust way in coming up with the metrics we need. And again, it's a very ultra high speed shine fluid tomography technology with 4,000 frames per second. So you're capturing things on the millisecond range, but you can see it in slow motion to understand what's going on. It's non-contact. Again, 140 images in 31 milliseconds with an air puff, which is so quick that you'd never be able to see it, but you slow it down so you can actually see what's going on and make some sense out of it. And from that came some of the metrics that Renato talked about, which was the CBI and the TBI. And the CBI, which had to do more with the corneal biomechanical index, had to look at certain metrics such as a stiffness parameter, an integrated radius overall on the back surface of how much did it bend in, the arc teeth threshold, and a DA ratio. So these various metrics have all been validated as more important. And what was done is a more logarithmic scale, so that if you were closer to normalcy, you would expect a value near zero or somewhere in this range of green, but certainly less than the 50% mark. Whereas if it was something more abnormal, you would see something in the red here that was greater than 50%, a lot closer to the 1.0 mark, as you can see. So in this case, a normal mark here was 0. Here you can see with that patient I kind of talked about before, 1.33 based on the Bailyn-Ambrosia score. And you can link the shape with the biomechanics to come up with the TBI, or the total biomechanical index, which again was more normal because it was less than the 50 percentile or 0.5. And this is a great tool beginning to link biomechanics with shape. So as we look at that, we say, okay, well, here's a candidate for refractive surgery with our typical normal Pentacam analysis. You can see the thickness looks pretty good. Here it's about 507 in the thinnest area. The shape on the back surface, the front surface, all looks uniform. It's against the rule of stigmatism, but very uniform. You know, is this safe to go ahead and do refractive surgery? And if you looked at the Bailyn-Ambrosia display, you'd say, okay, 0.68, nice low, looks like it's very symmetrical, should be perfectly fine. Let's go ahead and do surgery. But, we have a Corvus, so let's link it up together and take a look. Well, it turns out the CBI value is a 1.0. It's very abnormal. It's telling you this is not normal biomechanics. And when you couple that with the normal shape, it gave a total biomechanical index that was greater than 50%, again, higher than the 0.5. So this is a high ectasia risk. Don't do surgery. Don't do LASIK, at least on this particular patient. Because this information from the Corvus is screening out things that are very subtle and giving us some warning. We look at the fellow eye of this very same patient, and sure enough, that fellow eye was very abnormal biomechanics and on the shape, giving a very high index. And that tells us, yeah, the fellow eye was keratoconus. And here was a form for a situation that we would have known if we looked at both eyes. But had we only had the one eye to look at, we might have missed it unless we had the Corvus to look at the biomechanical indices. And that's why I say this is really the future, because Corvus is available, but not yet in the United States for biomechanical testing. You can use it, and we have one for IOP measurement. And if we're doing studies, we can use it for the biomechanics, but it's not been fully approved in the United States. And that's why, it's what I consider still the future. And many of you around the rest of the world may already have this. Beyond that of the Corvus is other metrics for looking at biomechanical indices. And two that I just want to highlight is OCT elastography, which was sort of highlighted by BJ Dupes, one of my partners at the Cleveland Clinic before moving on, as well as Vinicius DeStefano, who was his PhD student, also a Brazilian, who is now a resident with us in Nebraska and will be joining us in faculty in a couple of years because he wants to stay in the US. And I'll talk about that in a minute, as well as Breon spectroscopy, which looks at some of the mechanical abnormalities with a whole different way of looking at biomechanics going forward. So here with OCT elastography, you can see this video where you have a plate that's compressing, and looking at the OCT laser speckle, you can see that the change in the speckle movement within shows us very small subtleties of elasticity based on the mechanical disturbance. Now, we talked about air puff with Corvus because the air puff is not touching, but the air is still touching. In this case, we have a more mechanical displacement, but it's that uniformity, and then looking at how the OCT speckle changes that tells us what's normal and more abnormal with the elastography. And this may be something that will be modified in the future for clinical use. And then Brilliant microscopy, also a non-contact method, no air puff, has to look at just shining incident light on your substance and then looking at how the light scatters based on the subtlety of the molecular composition inside in terms of the mechanics. And the inelastic versus elastic rays would have a little different pathway in coming out of that, as well as an acoustic phonon, and it's directly correlated to the elastic modulus going forward. So it gives us some great information about elastic modulus without a direct contact. So kind of in conclusion, and I'm not completely done here because I'm going to go on to something more, ectasia detection sensitivity really has to do with levels of how sensitive you want to look at it. And we are continually drilling down on looking at greater and greater sensitivity and specificity in defining this disease. Now, obviously, the manifest to a slit lamp, if you can see on a slit lamp examination or just looking on a side view and see, wow, that's a cone, you know, that's obvious. You know, no one's going to want to do refractive surgery on that patient. Of course, then we got topography, which shows that abnormality in terms of actually reflection off the front surface alone. We look at tomography, which now gives us metrics to look at front and back surface and thickness all together. And that's really one of the most robust that's out there that everyone should be trying to use now for detecting potential keratoconus risk. To beginning to link that together with biomechanics, and I have to say right now, and Renato sort of said it, I think the gold standard out there is to have a Corvus together with a Pentacam, and to look at those two metrics together and how it makes sense in terms of a total biomechanical index when trying to screen out and have good judgment in terms of who's safe and who's not. But then I always ask the question of, is there something that's beyond actually elastic modulus? And could there be something even at the chemical composition or the genetics of that individual cornea itself? And with that, I want to talk a little bit about beyond biomechanics and a case of ectasia and an otherwise normal smile procedure. And it was a few years ago that there was a publication by Moshafar looking at post-smile ectasia and what otherwise looked like normal preoperative eyes that had smile procedure. Maybe they weren't entirely normal, you know, when you look at some of them further, but this is a particular case out of Bangalore, India by Dr. Shetty, where he did a very high myope with smile. You can see the overall shape showed good symmetry overall, thickness, everything looked good, shape looked good. You looked at the overall Pentacam data, 0.96 with the total D score. So it seemed reasonable to do a smile in this case instead of a LASIK. You can see here some of the metrics, the thickness at the thinnest pack, 540, that's pretty much normal thickness. And if you looked at the Randleman score, you'd say, well, if it was a LASIK, or I should say the PTA, if you looked at it, was a LASIK, it was a little over 40%, but it's not a LASIK, it's a smile. So it should be a little more forgiving. Again, the total Randleman score was only a 1. So things look otherwise like this should be a good candidate for smile. Here you can look at this patient who had smile 2 years later. You can see here 2.5 years or so, there's a central elevation starting to form in the left eye. And then looking another 6 months later, it's progressing. And so we're getting progressive ectasia that we're seeing changing between a 2.5 and a 3-year visit. And the difference shows that change. And so this patient has progressive ectasia in otherwise an eye that seemed to screen out as normal. It turns out this patient also had the corvus measurements, and those corvus measurements were normal as well. So again, looking at some of this detail here, the right eye shows maybe a little bit of change over that period of time, left eye more clear elevation. So right eye suspicious, left eye clear ectasia. And yeah, here's the corvus that I was mentioning. You know, the TBI was 0.38 pre-op in the right eye and 0.13, even lower in the left eye, the one that developed ectasia. So here, even the corvus did not screen it out. So what's going on? Well, Dr. Shetty is very progressive in terms of his research in keratoconus, and he takes all of his smile lenticules and based on ethics committee approval, stores them in preservative media, brings it to his laboratory, freezes it, and then stores it and labels it so that 3 years later, he could come back and say, let's look up the tissue of this patient that developed ectasia. And that's exactly what he did. 3 years later, he says, we have ectasia. Well, we're keeping that sample in storage. Let's go to the repository, find that sample, pick it out, take it and process it and do quantitative PCR on it to begin to look at certain gene expressions of certain proteins within that cornea to understand, was there something abnormal on a molecular basis for in this particular eye that might have been the reason why it led to ectasia when everything else looked normal. And it turns out from this, there's lysel oxidase, or LOX at short, is a natural cross-linking agent in the cornea. And it was significantly reduced in the ectatic eye, as you can see here by the black to the left. It was lower in the non-ectatic eye that looks suspicious compared to normal eyes. And again, this was looking at match controls with the tissue that was actually analyzed. And other things like collagen 1 alpha 1 was more normal, MMP9 was normal. It was really this one area that was seen as more abnormal. So we're looking and beginning to say low levels of a natural cross-linking agent in the cornea could be setting up the risk for biomechanical weakness, which could be setting up the risk for an ectasia or a keratoconus down the line. And so we're drilling down to more and more microscopic levels. We published this in an article in Journal of Refractive Surgery back in 2019 of bilaterally asymmetric corneal ectasia following SMILE with asymmetric reduced stromal molecular markers, but otherwise everything else was normal. And kind of concluding this whole section, lox, and you think about bagels and lox makes everything better. You got your nice bagel here with some cream cheese, pick some lox in there, makes everything better. And what I think is going to be interesting in the future is that there's a new startup company called Ivina, which was started by Bala Ambadi, who's an ophthalmologist in the US. He's commercializing a LOX promoting topical agent. So there'll be a drop in the future that will promote LOX formation within the cornea and even the sclera for high myopia that he's hoping to commercialize and sell that might be useful as a strengthening agent in the midst of doing refractive surgery, especially if you can determine that that patient is more at risk. So that's the conclusion of my talk from the Trulson Eye Institute, and I open up for any questions.
Thanks, Ron. That was fantastic talk, as usual. That's very interesting, this LOX promoting agent. Now, I have a couple of questions for you regarding the screening, because I used to learn with you how to screen out patients. Now, my question is today, how do you manage to have your screening evaluation with the different technology you have? For instance, if you are screening everyone with Pentacam, and for some patients, which is what I remember from at the Cleveland Clinic, you are using the Galilei, and for which specific case you are using the Galilei for, or which specific feature of the cornea you are more comfortable with the Galilei?
Yeah, so we decided in getting started with our refractive service here. So I moved from the Cleveland Clinic about 2.5 years ago to come out here to Nebraska, and I had to set up something from scratch. I had to take a design a practice from nothing, and we're already picking up and doing some great volume. But we ended up getting a Pentacam AXL and as well as a G6. And we actually now have two Pentacams. One's an AXL and one's is more the HR. And we have two G6s, or I think one's a G4 maybe. But we have the extra one because we have a satellite location, and we really want to look at both of those tomographic devices. I have to admit, with the Corvus and the Pentacam, probably I rely more on the Pentacam measurement because of the Corvus than I do on the Galilei, but I still like to look at the Galilei because of the validity of the asymmetry on the back surface, which will really begin to tell us something that's more abnormal.
Now, for the confused refractive surgeon, let's say that you have in your clinic the G4, the G6, and the Pentacam and the Corvus and the epithelial mapping, and even you remember Randleman's scoring system way back from the 2008. What would you say gives you the best prediction for ectasia out of all of these scoring systems?
I would say if I had to pick one kind of technology to go with, I think it's kind of like Renato said, if you have a Pentacam with a Corvus, that's a pretty robust unit right there to give you information, to give you some confidence. So if you said, gee, I can't afford all those devices to look at all those things, just tell me what's the best device to maybe go forward. I'm a great promoter of Galilei. I think it's a good device, but because of the Corvus being an added feature with the Pentacam, I'd almost kind of say you got to go with the Pentacam if you really want to pick one. Now, we happen to have the OCT for OCT mapping. I don't do OCT mapping on every candidate, but if I have a more suspicious candidate, I'll sometimes say, you know what, let's get an OCT epithelial thickness map. I just want to see what's going on, if there's anything that's abnormal there. And even like I get complex eyes. I got people who come in that maybe had RK in the past, or they had some sort of problem, where I have to do an enhancement with topo guided. And I want to know how thick is the epithelium, how much is actually true shape of the cornea and how much is being modified by what the epithelium is either smoothing out or it's clumping up in certain areas. So it's a useful tool for epithelial thickness mapping. And I know there are a lot of surgeons that would say it's the most sensitive metric for determining keratoconus risk. But in my mind, I still like shape with biomechanical indices as my go-to for screening patients.
If I may, thank you for your question and for your answer, Ron. And I would say that epithelium is a reactor by definition. So the epithelium would modulate to the change that we have on the stroma. So when people say that epithelium is the most sensitive way, it may be, but by definition, the epithelium is a reactor for the changes that we have on the stroma. If you remove the tissue in the center, in myopic refractive surgery, you have thickening on the epithelium. If you remove tissue in the periphery for stiffening the cornea, you have thinning there and thickening in the periphery. So the epithelium reacts. So the epithelium should not be, by definition, the first change that occurs.
And I assume that also thinking about the types of refractive surgery, when you have all of these borderline corneas, I assume that you would be more liberal doing surface ablation related to in comparison to lamellar refractive surgery in some of these indices.
Yeah, from my perspective, age is a huge factor. If someone is young and they've got suspicious looking corneas, if I'm mildly suspicious, I might do a PRK and avoid using any mitomycin, because if you do a PRK and you get a little haze there, guess what? That haze is stronger scar collagen that's forming more of a protective layer to prevent the ectasia from happening. So I think in some ways there's been some surgeons in the past who said, I can treat early keratoconus with PRK and not worry about them progressing. Well, I never really wanted to do that. If I know it's keratoconus, to me, it's a risk. But part of the philosophy of that is if you get a little bit of subepithelial fibrosis after your PRK, that's actually a stronger collagen matrix that's helping to keep ectasia from happening. So I think PRK is a lot more forgiving procedure than LASIK is. But I will do LASIK on somebody. For instance, I had a doctor's wife, one of my partner's wife, not one of my partner's sister-in-law came to me and wanted to have LASIK surgery done. And she was a high myope, and her PTA came out to about 48, close to 50, which is a lot more than 40%, even though she had normal maps and everything. And again, if she was 22 years old, no way. I would have never done LASIK because I would have been way too at risk. But she was like 48 years old. And I said, look, she's older. She has a stiffer cornea. I went ahead and I did thin flap LASIK on her. And she's like 2015, as happy as can be. She's about, I don't know, a year and a half out and is doing very well. Now, maybe she'll end up getting ectasia later and I'll be burned, but I don't think so because she had that older age, and older age is very much in your favor for being a little bit flexible with the metrics that you're using.
Absolutely, I agree that age is a real factor to consider here, and that it's strange that none of these sophisticated systems like the Bailey and Ambrosio display and all of the others don't factor in age as one of the parameters for decision. Why is that?
Michael has been a big promoter of including age along with the BAD-D for candidacy of LASIK and surface ablation. So he has a table that goes that age is a very important factor. So I think age is you don't need any machine for having age. Age is a clinical parameter. But my point is that if you have biomechanical index and probably this case that Ron just mentioned of the wife, his partner, probably the TBI was not so bad and the shape of the cornea was very normal. So I agree that you can weaken the cornea beyond the 40% PTA. But the point is that if you have no clue about biomechanics, I think age is going to be a very important factor. So I also believe that age is always going to be important, as the patient can, during the aging process, have more progression of myopia. I have seen patients with eye elongation that I did surgery when they were 21, and now they have myopic regress. And if I didn't have the axial length, I wouldn't be able to explain why the myopia is coming back, because the cornea is stable. But it's definitely a need for a multimodal. There's a good question, people asking about the OCT to replace shine fluid. I think they would coexist. It's like when we started doing wavefront analysis, people would say that we don't need topography anymore. But if you have whole eye wavefront and corneal topography, eventually you have integrated intraocular optics. Eventually one machine is not replacing the other, one measure is not replacing the other, but making it even more important.
Do you guys have any limitation about doing LASIK in young patient, even when the cornea is clearly normal? For instance, I don't know if it's still working this way in the US, where the Randleman score is kind of what you will have if someone suit you, then they will look at the Randleman score. I remember something like that when we were at the Cleveland Clinic, and therefore, if you do LASIK surgery in someone that who is 19 years old and everything looks perfect, he has already 3 points, which means that they are more considering doing PRK anyways. Now, what's your point with that? Are you usually up to 2021? Are you doing PRK anyways, but no matter what the refraction is?
Yeah, in my case, if somebody is 18 or 19 years old, and they have good normal thickness corneas, you know, so they don't see any questionable thinning, and the shape looks great, and they've been stable for several years. I would say, yeah, they're okay as a candidate for LASIK. If they happen to be a high myope, like -9, then I'm probably going to pause, you know, because I'm going to say that's a lot of change to be doing, and maybe an ICL or something else would be a better suggestion for that. I know that Brian Armstrong, who was my fellow and has been in the Middle East for the last 8-9 years, he's been he has a lot of keratoconus in that population. And so his ICL rate is about 20% of his refractive surgeries. And in China, it's a good solid 10% of refractive surgeries. So, you know, in the US, it's less than 1% that we're doing ICL, and we don't have the EVO with the hole yet. Maybe it's going to increase. But other places around the world where maybe they have more at-risk eyes are going to be a little more prone to look for a different solution like an ICL, especially in the younger patient.
Right. One more question about you discussed the contact lens removal before the screening. Now, there are a couple of recent studies actually. We used to remove and to ask for a soft contact lens removal at least 1 week. Some practice are asking for 2 weeks removal. But there are a couple of recent studies, including one that you might know, but it's still not published, from Shalhorn. He told me over the phone that they are going to publish that soon, showing that wearing contact lens and removing the contact lens 1 day before the surgery, 3 days before the surgery, or more than 3 days before the surgery didn't change anything in the outcomes. Any thought about this?
Well, I know that, I mean, I guess in that particular study, perhaps the amount of warpage that was happening from the contact lens may not have been a lot, you know, but we know that every eye responds differently to the pressure of a contact lens. And so it may be that in their cohort, there wasn't enough of those patients who had more of a warpage response. Because if you clearly see something that looks like a warpage or like a cone, and you got to differentiate, you want to see, is it going to change? Is it going to change in a way to become less warped? Or better yet, can you do epithelial thickness mapping to show that it's thicker there instead of thinner there? I think that's where the epithelial thickness mapping comes out really strong, if you have this question about, is it contact lens warpage or not? And yeah, the numbers I kind of get were sort of what was some of the initial stuff. Right now, I would say we say stay out for a week if it's a soft spherical lens, and stay out like 3 weeks if it's a soft toric or you know, a gas permeable lens. And if I'm doing Contura, I'll make sure that anybody with contact lenses has to be out for at least 2 weeks.
Can I ask you a question? Are you doing endothelial evaluation with a specular microscopy or something similar in a routine basis, or you just look at the endothelium with the slit lamp?
I've not been doing endothelial evaluations, mainly because historically it's not been something that needed to be looked at. In fact, that's a test question on the American boards, is which of the following tests is not needed in refractive surgery? It's an endothelial cell evaluation. But it may be that as we understand more and more about keratoconus and disease, we'll start looking at stuff like that too.
One of the things that we are looking every time with the Pentacam and also the Galilei, we are collecting many patients with that, is the densitometry map. It's a very interesting maps for a couple of things. First, to early diagnose any type of epithelial dystrophy. It's very interesting. You can pop up very easily some epithelial cysts. So I kind of now, every patient that I have, I go always over the densitometry map. It's very interesting. And I got this week twins patients coming to the clinic, and I look at the densitometry map in a usual way, go over 360-degree, and I see something on the endothelium that I missed on the slit lamp exam. It was a very truncated polymorph dystrophy on the periphery of the cornea. They had both in one eye only, the right eye for both. Genetic is crazy, really. That was fantastic. That was exactly the same things for the twin. And we could see very clearly in the densitometry map. So I think there is a lot of value of this map as well, especially when you are considering LASIK and you really don't want to miss any epithelial dystrophy before.
That's good.
So Renato, you were talking about the endothelial cells because of considering PRK versus LASIK. That was
as well, you know, there's a good review. The literature on LASIK and PRK on endothelial disease is interesting because there's not much there. We know that the procedure does not affect the endothelium, as Ron just mentioned, but if you have a endothelial disease and you do LASIK, you may have a lot of problems because of the flap adhesion. But of course, endothelial disease and slit lamp biomicroscopy, documenting the endothelium is an issue. But I have a couple of cases that came recently with PPND, the posterior polymorphous corneal dystrophy, and this is related to keratoconus, and these patients have some thin corneas and weak corneas that you cannot explain. So those patients, I tend to do PRK. I don't even do SMILE on those cases. But and those cases are not so good for intraocular surgery because phakic IOL will not be a very good surgery for them. So surface ablation is what is there, but they need to understand that they have some condition that may progress to disease with or without the surgery. If they ask me if they cannot have the surgery, say, I think it's better to say you cannot wear contact lenses because contact lenses may affect more than the film than refractive surgery. But this is something to be debatable because those cases are interestingly like borderline. But I know most of my professors and colleagues in the United States, they don't even pay attention to the endothelium at all. And there is much more Fuchs dystrophy in the United States than in Brazil. And that's an interesting fact, and that this is not a big problem.
So in the US, there was a nice paper that came out some years ago. I can't remember the authors, but they had 3 patients who had corneal guttata and a family history of Fuchs that had LASIK. And all 3 of those patients lost 2 lines of best corrected vision because it was enough to kind of tip them over the edge, and there was some fluid that was being retained in the interface, and the fluid in the interface caused loss of best corrected vision. So to me, it's enough to say that if I see guttata, now I can get a specular and have some documented number, but if I see guttata, I'm going to be asking about Fuchs dystrophy. I'm going to say, anybody in your family ever have a corneal transplant? Is there anything that's there to be a real suspicion? Because that may really change the direction I go in terms of PRK or LASIK. But in the absence of the guttata and with no real family history of Fuchs, I don't see where it's a real thing that needs to be looked at.
Renato, you just mentioned that you are still doing SMILE. Do you think there is any future for this procedure here in Israel? This is really abandoned by most of the surgeons who used to do it over the past few years.
Well, I consult for Zeiss. I like SMILE, but I was more optimistic about the benefits of the biomechanical impact of SMILE considering LASIK versus SMILE. I must say that the only ectasia case that I ever had, that I ever produced, was a high myopic patient after SMILE. And going back, I would not have done it as a SMILE because it was like a -10 with a TBI of that I today can see the TBI in a retrospective way. It was too high for that. But I think SMILE has some advantages over LASIK, especially considering dry eye. It's not that it will replace completely LASIK, but eventually SMILE will find its place. And if you see the trends of SMILE in Asia is getting bigger and bigger. But I see in the United States, SMILE is getting popular and more popular, but it's like the first early adopters that flattened out and maybe decreased, but time will tell. But I see a lot of people asking me, why are you doing SMILE if you should do PRK in everybody? I would say there are some cases that I would say SMILE is better. A young patient with high myopia and not high astigmatism, I think SMILE is the best procedure before you go to the phakic IOL. So I still do SMILE, but I was more optimistic about the benefits. But I think it's still a good procedure, and probably things will get better and better when we have better centration, and hyperopic SMILE probably has some benefits as well. So time will tell. We as refractive surgeons, we tend to be early adopters, but we have to be careful with the new concepts as being definite truths, and we have to question them as well.
So my experience with SMILE is that I started years ago at the Cleveland Clinic when it was just spherical SMILE, and when the parameters were a lot more crude and was a little more challenging, and my visions were clearly better with LASIK and topo-guided LASIK than with some of my early SMILE patients. But since coming here, I've got a VisuMax laser. I've started doing SMILE as well. The parameters are a little better, kind of like they are outside the United States, and I can treat some astigmatism. And my results are good so far with SMILE. I wanted to kind of throw out, for me, I think SMILE has a very valid place in the future. And again, as Renato said, you got to look at Asia and what's going on. On May 21st, Eye Hospital, which is the largest eye hospital system in the entire world and has 400 plus clinics in China, did an analysis of all of their refractive surgery cases in the last 3 years. And they came up with demographics of age, levels of myopia, type of procedure, everything as a press release. And I think they had something like 2.4 million viewers of this press release. It was astounding. I was on it, listened to it. I had some things that contribute to it. But in the analysis, 52% of all of the procedures, 1 million cases they did in 3 years, 52% of them were LASIK. And of that, I think it was something like 22% of the 50% were topographic guided LASIK. So they're doing a lot of topography guided LASIK relative to the LASIK. Almost a quarter of all our LASIK is topographic guided. But that's 52%. 32% was SMILE. So you look at it and say, well, almost a third of all the refractive surgery was SMILE. And that's pretty surprising, because you're going to have some clinics that are not as developed as others that maybe are just going to be doing LASIK alone. And then you got the high volume SMILE centers that are just doing almost all SMILE. Only 5% was PRK and 11% was ICL. So that was a surprise for me, as how high SMILE was and how high ICL was. In, China is the market leader, and Ayer is the biggest. Ayer does close to a quarter of all the refractive surgery in the country of China, one particular entity. And so I think they're a good predictor of what Asia is doing. And if Asia is the market leader in the world right now in terms of refractive surgery, that's a pretty good place to look at and try to understand where might we all be going at some point in the future.
Excellent point.
All right. So Ron, Renato, Avi, thanks a lot. That was a very educational and always great times to hear your lectures. Guys, I really hope that next time we'll be able to do something face to face. Was good anyway to see you, but I really hope that we can finish the lecture and then have our small talk, have a beer, and you know, that's what we are missing this year. Anyway, it was great to see you guys. Thanks a lot. I will send you the recording very soon, and I hope to meet up pretty soon.
Thank you.
That's
Bye.
good. Thank
Thanks
you
a
so
lot.
much for
Thank
including
you
us.
very much.
Thank you. Bye,
Good to
guys.
see you.
All right.
Bye. Bye, Ron.
Have a
Bye,
great night.
David.
Good to see
Bye,
you,
Avi.
Renato.
Good to see you.
Bye-bye.